Good to see everybody this morning. We wanted to spend a little bit of time this morning reminding people of the data that we have available in Medic. So, in addition to all the information that our abstractors are hard at work collecting, Medic's receiving electronic data for every single emergency department visit at all of the sites. And with that, sites are encouraged to use these data for work related to Medic or for other academic or quality improvement pursuits, including research, publications. The process for requesting data is something that the coordinating center is here to help you with. And that data request, as long as somebody from your Medic QI team is involved, can come from anybody at your organization. Um, and just know that we're here to help navigate this. And in the next few little snippets of presentations, we're hoping that we can inspire you all with some new ideas on how to use Medic data. So we're going to hear from three different institutions and several different ways that they've used the data from Medic, starting with Raj Arora from Children's Hospital of Michigan.
Thanks, Michelle. Good morning, everyone. Happy to be here this morning. Simply want to thank Team Medic for this opportunity and also supporting our project and endeavor. So to give you a little context about this project, Children's Hospital of Michigan, like many other children's hospitals, have two ER sites. So our primary ER site is our downtown campus, which is a level 1 trauma inner city. So basically any and all capabilities and support system to take care of our patients. And then we have a satellite site, which is our Troy ED, basically a freestanding ED where it's just us meaning the PEM providers with some minimal support in terms of labs and imaging. So over the years, Medic has been instrumental in providing us data for both our sites regarding the CT and the chest X-ray utilization, and we have been able to track and compare our performance. Unexpected, the results were somewhat different at both sites. So we were simply intrigued and decided to explore if the site per se impacts the provider decision-making and or their resource utilization, and also if the provider level of experience plays any role into it. So to this end, we are planning to compare the CT and the chest X-ray utilization data for our PEM providers who work at both the sites and see if there is any difference whatsoever and factors that may be contributing to it, especially their experience. To make for a somewhat comparable and homogeneous sample and control for severity, we only would be looking at treat and release patients, basically the ones who got treated and discharged versus the admitted ones. We are very much in early stages at this point of time of doing the proposal. So if anyone has any thoughts or any suggestions, please have it come our way. We also intend to supplement this data with structured interviews of our providers to also gather their perspectives. So we are just happy to have Team Medic on our site to provide us with the high quality data. So yeah, that's where we are.
Wonderful. Thank you. And next, we're going to hear from Adam Ostema. It looks like he just came into the waiting room, so we might have to give him a second to get situated on his work, really trying to advance the care of patients with pulmonary embolism, specifically on one project that's grant funded for patients in rural settings. And if Adam's ready to take over the conversation about this in the next study, happy to hand it over to him.
Hello. Sorry about being late. I apparently didn't have a link to this meeting. I just assumed that I was on it, but that was on me.
You were right on time.
Sure, yeah, thanks for giving me a minute just to inform everybody about these projects. This is two studies that we've been doing or a study that we've been doing in Corewell Health West with ECS, and then another study that's under grant review right now that Medic has supported. So the Rural PE project was a lot like the Medic Alert project in that it was focused on trying to encourage safe discharge of newly diagnosed PE patients from the emergency department, but we focused particularly on our regional facilities and critical access hospitals that are part of the Corewell Health Network. And so, you know, kind of piggybacking on some of the principles that we were using at Butterworth, we revamped our PE evaluation algorithms, kind of decision support tools, order sets, and we also established a new clinic that was staffed by ED physicians that was available for follow-up of any PE discharges from the rural setting. Our theory was that perhaps we were not using our risk stratification tools as consistently in the regions, and we also wondered if if lack of follow-up might be a barrier. And so patients could have virtual or in-person appointments with the virtual follow-up clinic. And so we implemented this and did essentially a before and after comparison. The analysis of that is ongoing, but preliminary results would suggest that we saw a huge leap in the use of the SPECI tool from around 50% to over 90%. But we didn't see much of a change in our discharges. And in part of that was because in the rural facilities, we were actually discharging a pretty high rate of our PEs already in the neighborhood of 30% of normotensive PEs. And so we didn't see much gain in that. There'll be some interesting offshoot studies about why that is. But the other thing we found is our PE follow-up clinic was not used very much. Most patients, we had a pretty aggressive follow-up plan where we actually called everybody who was discharged from the ED a couple of times. And the vast majority of patients preferred to follow up with their PCPs. And so we did see some patients through the clinic, and we had a few wins there, like getting troubleshooting script problems and things like that to ensure patients really had access to their anticoagulation. But there'll be a lot more details on that one to follow. So that's the rural PE project, which is now done. And then we're also very grateful to Medic for supporting our application for another grant. This one kind of grew out of some of the barriers we ran into in rural PE, which is that we found a lot of patients wound up getting screened in for hospitalization either by um, the conservative nature of the SPECI score itself or by right heart strain, even borderline right heart strain that was seen on CAT scans. And so we wondered if maybe bedside assessments for PE could be bolstered if we did a little more robust evaluation of patients in a couple of different domains. And so this project is a little ways away from the implementation world. This is more exploratory, but our plan is to enroll patients with a newly diagnosed PE who are going to be admitted, but then obtain some extra information about those folks, both about their sort of medical frailty using some validated frailty scores, but also performing more of a dynamic assessment of their hemodynamic stability. We notice that sometimes patients laying in bed and getting vital signs taken doesn't really capture a person's stability or instability very well. And so our theory is that if we capture some ambulatory vital signs, we might actually be able to get a clearer picture of just how stable or unstable a person is. And then there'll also be a component of exploring bedside ultrasounds in direct comparison to using CT-RV estimates to determine those patients who actually have strain. So this one is not ongoing yet. It's under review at the moment, but we hope that this will be up and underway and perhaps may help us refine our algorithms a little bit, give ED clinicians a few more tools to try to find the patients who need to be in the hospital and get them there, but perhaps identify a few stable patients that right now might be uh, screened into hospitalization through an overly sensitive system. So those are just two projects that we're working on right now. I'd be happy to take any questions, but thank you again to Medic for the support of these projects.
Thanks, Adam. I know we've got a packed agenda, so I think I'm going to move things along to hear next from John Greco on a study that has to win the Persistence Award. This work started more than 8 years ago when I was still at University of Michigan, and it's just a major accomplishment to see this now published in pediatrics. And John, just let me know when you're ready for slides to be advanced.
Yep, no problem. So yeah, I'll be brief, but for a very long-winded study. But as you all know, we've been working on chest X-ray stewardship for a while, and put out the toolkit several years ago now. And what our group did was look at 114,000 visits for respiratory complaints in children at 38 of our medic EDs, and charted that chest X-ray utilization data monthly. Our primary analysis was just looking at all visits for asthma, bronchiolitis, and croup over that period. And we did SPC analysis or statistic process control charts using QI macros. Pretty easy software to use, actually. And broke it down a couple of different ways. The primary way was again just looking at our overall chest X-ray use in those patients. And you can advance it now. So the graph on the left is just all of our sites charted together over that time period from May 2017 to April of 2023. And as you can see, our chest X-ray utilization improved pretty significantly over the course of that time period, with the toolkit rollout was official sometime around here. But we went from utilization at 32.9% to forget what our final was, like somewhere around 22% at all sites. Obviously, there was a blip there during COVID, but our overall um, utilization improved and our variability improved, as you can kind of see with our upper control limits and our lower control limits just getting significantly better over the course of the study period. We also broke it down by how we used to say high risk and low risk patients. So patients with a potential indication for chest X-ray versus patients without. And we saw improvement in both of those areas, but had better improvement in our, it's especially in terms of like the variability and the overall rate in our kind of low risk patients, the ones who were really trying to avoid getting X-rays in, and you can advance. And then we also broke it down by our general EDs and our pediatric EDs. These dotted lines here when we started measuring, and then when we had our rollout is B there. And you can see we had improvement in both. We had great improvement in the pediatric EDs. And then our incentive sites and our non-incentive sites, and that's the our sites that chose to have either P for P or VBR incentive for the chest X-ray measure, and our sites that chose to have chest X-ray utilization in pediatrics had awesome improvement over the course of this too. So, I mean, it's great use of our data to show these things and to publish our methods and get it out there to the world, which is awesome. And also just proof of like how everybody in the collaborative is improving and doing really well over the course of a pretty long time period. So yeah, it's great.
Thanks, John. And now we're going to hear from Emily Mathias on some qualitative work related to pediatric readiness.
Good morning, everybody. All right, so we are in the final editing stages for our paper describing our qualitative findings based on the debrief interviews that we conducted following completion of the National Pediatric Readiness Assessment at our medic pilot sites that participated. This analysis was actually led by one of the graduating Peds Emergency Medicine Fellows at Children's Hospital in Detroit, Dr. Jamarina Thrush. And initially, she presented it at our annual Pediatric Academic Societies meeting last year. The objective of this work was to qualitatively describe the lived experience of completing the National Pediatric Readiness Assessment, kind of to help inform best practices for our future medic work in the pediatric readiness space. But we decided to publish it because we wanted it to also inform some best practices for future national assessment periods, which one is coming up, and I'll be talking about more later on today. So we had really what we had for our data was interview transcripts from each of our pilot sites, and we analyzed them using grounded theory methodology, which yes, bear with me, but I want to give a quick overview on that for those of you who may want to know a little bit more about a way to perform qualitative research analysis and then like what's considered an academically rigorous way. So this approach involves systematically reading through transcripts and assigning descriptive labels, which are called codes, to meaningful segments of text. So, for example, in our work, when the participants described feeling uncertain completing the assessment alone, we coded that with words such as solo completion and uncertainty. So, different excerpts can have multiple codes, and you can kind of segment them off. As we coded all the transcripts, where we were constantly compared new segments to previous ones, kind of looking for patterns. And then your related codes naturally cluster together, and then clusters become subthemes, and then then hopefully you pull larger themes out of that. So for our data analysis, we actually generated 294 coded excerpts and 125 unique codes. And that was able to be organized into four major themes. There's actually computer and web-based programs that can help you in the organization in the somewhat arduous process, but these programs are really helpful. I just pulled out one of these themes to show you today so you can kind of have an idea. We identify, so this is kind of an example of how this analysis process looks in practice. So one of our major themes was multidisciplinary involvement to optimize accurate assessment completion. And then one of the excerpts that define this theme, I thought so well, I'm going to try to highlight it here. So this is the one on the third one down. So it felt a little daunting being the person filling it out just because you're not really sure. The questions seem pretty black and white, but yet at the same perspective, it's like, am I actually answering what they're asking? So, and as you see with the other extras, they kind of all speak to the same thought process and theme. So the key strength to this approach from grounded theory is that your themes are emerging directly from what the participants told you instead of rather being them or rather than them being predetermined by the researchers. So as I mentioned earlier, we're in our final stages of editing, and we are going to hopefully be submitting in the next few weeks.
Thanks, Emily. We hope everybody's feeling inspired and recognize these timelines are coming up a little bit quickly to generate new data, but wanted to be sure it's on calendars that ASAP's meeting submissions for abstracts are between March 4th and June 3rd, and the American Academy of Pediatrics NCE deadline is April 10th. There is kind of awaiting news on the outcomes of these abstract submissions to SAM for 26. So I think any day now, Keith and Alex will hear news as to whether or not associations between key decision moments and diagnostic quality for suspected PE in the ED is accepted, as well as a project that looked at variation in drivers of spending within 30-day emergency department-based episodes of care. I think this is the last slide I have, but also want to call attention to the resources that are available for publications, posters, abstracts on our website. So if you go under members, committees, data and publication committee, you can see resources, you can see links to the data request guide, you can see poster templates. And we also want to call attention to language that needs to be present in all publications and disseminated information that explains the relationship between Blue Cross Blue Shield of Michigan and Medic. So if you do have things that are going out into a public domain outside of the four walls of your emergency department or hospital system, we want to be sure that that relationship is appropriately acknowledged. And if you've got questions, feel free to reach out to any of us in the coordinating center. I guess this is the last slide. But in our October meeting, we're very much excited about the opportunity for you all to be sharing your work with each other. I think the conversations that happen at these poster boards are really interesting and exciting. This can be a poster that's been presented multiple times in other settings, but just presents an opportunity to engage in all the exciting work that's ongoing at our sites and offshoots of the tremendous data that are being collected and submitted on behalf of the network.